it is just a huge, unbelievable honor to be podcast interviewing Dr. Edward A. McLaren, DDS, MDC. He graduated from the University of Pacific in 1983. He graduated from UCLA in graduate prosthodontics in 1990. He's the former director of UCLA Graduate Aesthetics, founder and director of UCLA Advanced Aesthetics and Restorative Dentistry full-time graduate program, founder and director of UCLA Master Ceramist program, former professor, UCLA School of Dentistry, professor now at University of Alabama School of Dentistry, founder and director of University of Alabama Advanced Aesthetics, Restorative Dentistry, and Masters of Material Science residency program, founder and director of UCLA Master Ceramist program, founder and director of University of Alabama Master Ceramist program, author of the textbook, The Art of Passion, Teeth, Ceramic, Faces, Places, author of over 80 articles. How the hell did I get you to come on my show today, Ed? Thank you so much for coming on the show. You are amazing. You and I, when you and I got out of school, the new hot thing, we were going from amalgams and full gold crowns to PFMs and composites. Did you ever think you would live long enough that now the PFM has gone the way of the full gold crown and now there's all these new materials? It's so overwhelming. What is a young kid supposed to think about when it comes to ceramics, adhesion, aesthetics?
Well, good point. I mean, gosh, I haven't done a gold crown in 15 or 20 years, and not that I'm against gold, and it's a wonderful material, but you know and I know that our patients really want minimalistic dentistry. They want to look youthful today. They want to stay youthful, and with the materials and adhesion today, we have the ability to do that, and that's what's really exciting. And it's almost overwhelming that the choices that young dentists have today. And I'm personally excited, but I also feel overwhelmed with all of my knowledge today. So I would recommend to any young dentist, I mean, if they're in aesthetic dentistry, to focus on two things: understanding new ceramics and understand adhesion, and become a master at adhesion. And, you know, I try to break it down very simply for young dentists. There's really three choices today. If you really break it down, there's three choices. It's in ceramics. We can talk about composites. It's feldspathic ceramics if the restorations are minimalistic. It's something like Emax if you're bonding to dentin. And if you have to do a conventional crown, it's zirconia today. And, you know, there's various forms. So that's pretty much as simple as that. But, yes, you're right. I never thought we would see the day that we would eliminate metal when it's possible to eliminate metal today. I mean, it's certainly a viable option, a PFM.
Well, Ed, here's what I want to do. You're overqualified to teach the most elite 50-year-old cosmetic dentists around the planet. I mean, you're overqualified to teach them. I want you to bring it all the way back home because you're talking to a young crowd. 25% are in dental school, the rest are under 30. They got out of school. So I want you to just go into detail of two things. When you look at 100 million insurance claims form, you just see 4 spikes, and they're on the 6-year molars. The tooth number 3, 14, 19, 30. The tooth most likely to get an MOD, first molar. Most likely to get a root canal, first molar. Most likely to get a crown, first molar. Most likely to get extracted. It's all first molar. So she's 25. She's trying to build up her speed, and a MOD on a first molar and a full crown, or a crown on a first molar. Can you dive deep into an MOD on a first molar and then go into a crown on a first molar? What materials, what products, you know, because it's so overwhelming. There's so many companies, there's so many different bonding materials. I mean, what generation bonding agent are we on right now? 327?
Well, 401. 401. We're up to 401. Well, here's the, the good news the last 2 or 3 years, the universals, I'll get real simple with the bonding agent and I'll come back to the crown. Try to make it real simple. The bonding to enamel, you still should etch. But the good news is the universals are working to dentin. So we could keep it real simple. You could have a universal just in your practice today, and if you want to attach to dentin, you don't need to etch. You just don't need to etch. The universals are working, and if you want a good, stable, long-term bond to enamel, you should selectively etch the enamel, and it looks like you're going to be very safe long-term with that.
Okay,
And
but
that's what
name brands.
Okay, so you've got Scotch Bond Universal and you've got All Bond Universal. Those have been the two on the market the longest period of time, and I would recommend those two. Okay,
and Scotch.
You've got OptiBond XPR. Yeah, those are one bottle materials.
Scotch Bond is 3M, and All Bond
is Bisco. And the Kerr product, it's a 2-bottle material, so you got to use 2 bottles. Is OptiBond XTR. So to give you 3 right there.
OptiBond
XTR from Kerr, but it's a 2-bottle material. So if you want a 1-bottle material, it's the other 2 products. And 3M's has been on the market the longest and has the best research. Okay, but I would etch the enamel if you want to play safe. The research shows to at least etch the enamel, and you're pretty safe there. Bulk fill today, I have no problem with a bulk fill. For a dentin replacement, I would still use a micro hybrid for the enamel replacement if you're going to use it on an occlusal surface. Names come to mind. I kind of hate to give product names, but I would just use a good bulk fill if you want to for a dentin replacement, and whatever microfill you would micro hybrid you would like for enamel replacement. Okay?
I know you guys. I know you guys hate giving names, but give a couple names.
Oh, geez. 3M's material just escapes my memory right now because I just have a little bit of an aversion for that. I like Ultradent's material. Biolescence is the main material I use for occlusal surfaces. Okay, geez, I'm brain dead right now. I drove all.
What'd you say? Lessons?
Vitallessence from Ultradent. Yeah, that's the material I use the most. Okay.
Okay.
And I use on my patients.
Okay.
Okay. And then for ceramics today, if I'm doing a full crown, I'm using the STML from Noritake.
Say that again.
That's a cubic zirconia. I'm using I use STML from Noritake for a full crown. That's the cubic zirconia.
Can you find that STML from Noritake, cubic zirconium?
It's a cubic. The new cubic zirconia is much more translucent than the original zirconia. You can use it in a monolithic format. And meaning it's a very simple material to use and it looks very good. Other materials to use that work very well too that we have some experience with, the lava aesthetic. To give you 3 brands that look very good, I like to give 2 or 3 brands. And the argan anterior from Argan anterior. So those are 3 brands.
Anterior. And who makes lava aesthetic?
3M.
3M.
Yeah.
You know what I like about 3M the most?
Yeah.
You know?
What?
Well,
no.
Well, my oldest sister is a cloistered Carmelite nun, and it's in Lake Elmo. So when I go visit her to make it a business expense, I fly in. I go spend 4 hours and 1 minute at either 3M or Patterson headquarters, making a tax deduction. Then I go spend all afternoon with my sister, and then fly home all pre-tax. How cool is that?
Might not want to say that so live, but Phil, I'm sorry, it popped in my head. Filtech Supreme Ultra is my favorite posterior composite. That's from 3M. Filtech Supreme Ultra, and Vitallessence in the anterior from Ultradent.
Okay, so here's the belief on the street. What's that?
Well, I just try and keep that very simple. I use a universal, like I said, for a bonding agent, and then I'll etch the enamel. I'll use a bulk fill for dentin replacement for a buildup, and then if I do a full crown, I use a cubic zirconia, and you can keep it pretty simple without too high of an expense. Like you said, to treat that molar before it turns into an endo for a young struggling dentist.
Ed, do you think it's important? A lot of people mix and match. Like they'll use a bonding agent from Kerr and a composite from Ivoclar and a crown from, argon. Do you think that when those organic chemists with PhDs are making the product, that you should stay within one system, like use the Scotch Bond from 3M and the 3M bulk fill and the 3M Lava Aesthetic? Do you think it's a better product when the PhDs designed a closed system from A to B, as opposed to mixing and matching different chemistry sets and different composites and materials?
There are very, very few product lines that you can't mix and match. There are very few. In fact, the only ones that I haven't seen match is their 3M with their special chemistry with their resin cement, with their veneer cement. The 3M's veneer cement doesn't set with some people's bonding agent. So that usually is not a problem with resin cements. I have not seen that to be a big problem. So if, for instance, you happen to like Scotch Bond Universal because it's a very good universal, and you're using somebody else's veneer cement, I have never seen a problem with that. I realize companies will tell you to use their whole line of products, and you obviously know the reason for that. That's marketing and sales, but we have not seen a problem with that. They will co-polymerize.
Do you also, a lot of people believe that zirconium is for second bicuspid back and Emax is for anterior because of aesthetics. Do you draw a line like that, or do you not see a line like that?
And I would have agreed with that with the original zirconia. It was all tetragonal phase zirconia, which was much more opaque than this newer version of zirconia that has some cubic phase. Cubic phase zirconia is more translucent. Think of a fake diamond. It was 100% cubic phase zirconia, more like glass. These newer materials have up to 30, 40, or 50% cubic phase zirconia, which make them significantly more translucent. And they're very similar now to the MT, or medium translucent, Emax. They're not quite as translucent, but they're getting very similar. So here's where I break it down for me today, where I need increased strength, maybe in a crown environment or a bruxer where I can't do adhesion, where I can't bond. Then I'm going to use the zirconia. In more minimalistic situations where I can't use feldspathic porcelain, I'm still using Emax. I think Emax is one of the better materials that's ever been invented in dentistry, and I can use it in an adhesive environment. Zirconia, we can only bond chemically. We can't etch the internal surface. So the stability of a bond with Emax isn't that good. Emax, we can etch it like porcelain. And so I can use it with a non-retentive preparation. So the direct answer to your question is zirconia is not as aesthetic as Emax, but it's getting close.
Okay, a lot of the young kids, you say, well, what's going wrong with your compositor crown? For back to the kids out of school. When they come out of school, they don't need to learn how to place implants and full mouth rehab. They need to practice their filling, their crown, their cleaning. They need to do. It's like when you start playing football in high school, you need to practice your block, your tackle, your pass, your catch. So they need to get out of school and work on their basics. And I say, well, what's your main problem with your basics? The first thing they always say is sensitivity.
Okay, great. I'll tell you, one of the best things that ever happened to me about sensitivity was meeting Ray Bertolotti. And I don't know if that name means a bell to you, but he was the head of material science.
His wife used to be in the same Catholic nunnery as my oldest sister.
Great. Okay. and
I've known him for 30 years. Great guy. Just a great guy.
I can tell you that whether you etch or don't etch a tooth, if the dentist is willing to put a 5% glutaraldehyde product for 30 seconds on a tooth prior to doing any adhesive procedure, it will eliminate sensitivity. And it will increase bond strength. I'm sure you know Rella Christensen. She loves the stuff. She wants you to put it on for 2 minutes to kill all the bugs. It does not decrease bond strength. It increases bond strength with self-etch or total etch. and it decreases sensitivity. And you do need to be careful because it will burn soft tissue. You don't want to get it in anybody's eye or on their gingiva. So what I do is I put it on a little micro brush, whether I'm doing etch or no etch, non-etch, and I rub a little bit on the dentin, and then I'll do my adhesive technique. So if you were doing total etch, you would etch first, then you would put on a micro brush and rub it on the dentin for 30 seconds, suction off the excess, being very careful not to get on the gingiva, then go through your adhesive technique. If you're doing non-etch, obviously you're not etching, you put it a little on a micro brush, rub it on the dentin, just a little bit, you don't slop it on, suction off the excess, and then do your adhesive technique. Young dentists out there, please try that, and sensitivity will disappear. So the products to try. The original product was Gluma. That had the original patent. It's 5% glutaraldehyde, 35% HEMA, 60% water. The product of choice today was a product that actually Ray developed. It's called MicroPrime G. MicroPrime G from Danville Materials. It has the exact same formula. 5% glutaraldehyde, 35% HEMA, 60% water. The patents ran out and basically they copied it. Other things on the market, Cis-Temp desensitizer, Huraceal, Cis-Temp desensitizer, Huraceal, similar type products. There are some people that are against the use of the product just because, glutaraldehyde's toxic. You just have to be careful in its use. And again, don't get it on soft tissue. It will burn. But if you try that, I can guarantee you 99% of your sensitivity will disappear.
Ed, in the market today, there's 211,000 Americans have a license to practice dentistry. 150,000 are general dentists, 32 hours a week or more. 30,000 are specialists, 32 hours a week or more. Of those 150,000 general dentists doing 32 hours a week or more, what percent of them do you think use a rubber dam when doing an MOD composite on a first-year molar, 6-year molar?
I would guess less than 15%, maybe less than 10.
I love it. You're so real. You're so real. That's so obvious. What are your thoughts on that? Do you think they're still getting it done with 3-inch cotton rolls, or do you think they're just really doing second-rate dentistry?
Well, it's very interesting and poignant you mentioned that. There is a gentleman here that has at UAB, well, not here where I'm at, but at University of Alabama. His name is Greg Gilbert. And he is the chairman of the biomaterials department, or the whole department that I'm in. And he has the largest grant in history from the NIH, National Institute of Health. And it's a practice-based study grant. And actually, he is studying exactly that. He's looking in practices that use rubber dam and don't use rubber dam, and following success and failure, exactly what you're asking me. And pretty much he's not seeing too much difference between using rubber dam and not using rubber dam. Now, I'm not saying that's a license not to use rubber dam. Okay, oh great, Dr. Ed just said, or Greg just said, Gilbert, don't use rubber dam. So it really comes down to the real obvious answer is your ability to control moisture. It's not whether the rubber dam's on or not, it's whether you can keep moisture, saliva, and crud off of the tooth. And so if you can keep it with cotton rolls, if you can keep with something like an ISO-Lite or ISO-Dry system, some way to keep a contaminant, ISO-Lite or ISO-Dry, that's what I use. If I can't keep moisture off the tooth, then I'll put a rubber dam on. I don't like putting them on. I don't like working with them. But if it's absolutely necessary, I will use it. But that's the key. The key is clean and dry, right? And if you put somebody's head in a vacuum, that is the point. The point is clean and dry. I've seen some very good dentistry with rubber dams, and I've seen it without. So yeah. Anyway, I think you get the point.
Another thing that she's confused on, she's 25. You know, they hear so many different things, especially on Dental Town, that you shouldn't get a pulp exposure because you remove too much decay. There's affected dentin, effective dentin. You don't have to remove all the decay. You don't want a pulp cap. Other people say, no, you remove all the decay. If you get a pulp cap, do a root canal. Others say if you get a pulp exposure, use MTA or whatever. Talk about those issues.
So that's an interesting point today. I mean, I was taught in school, and I think the prevalence still today is if you get if you get a pulp exposure, it's almost a root canal. And that's usually pretty much what I used to do. Then I had the benefit of listening to John Kank a number of years ago, and then I kind of followed up with the Ray Bertolotti's gentleman I mentioned that if you had a pulp exposure, and then Charlie Cox and John Suzuki, some names you might remember, Howard, that hey, if the pulp was still vital and hadn't given any symptoms, and you could seal that, you could wall that off and keep bacteria from going in there, that you give the pulp a chance to heal. And John Kanka published some work on this, that if you could seal the pulp, that the body would heal itself. And my strong recommendation to you out there is maybe either take a look at that, and I started doing that. If it was a small pulp exposure and I could control and get some seal, I would then just do a big composite buildup, let's say, and I would see if the tooth would heal. And if the tooth became non-symptomatic, and 6 months later that I saw a dentin bridge in there, which would happen most of the time, I have to tell you. If the tooth was asymptomatic before and asymptomatic after, then I just go ahead and do an on-layer of crown. And the material that I'm using today is TheraCal Dual Cure. So it's a calcium silicate material that stimulates secondary dentin. You can use something like MTA, use essentially a bioactive restorative material. Now, if the tooth is super symptomatic, or you think it's an irreversible pulpitis, that's a different story. And we're assuming that the tooth is going to die, and the body has amazingly reparative capabilities. I'd give the tooth a chance to heal.
You talked about using Gluma before your protocol. Some people are really big believers in chlorhexidine gluconate. They want to scrub the prep out with chlorhexidine gluconate to kill the bugs. What is your thoughts on chlorhexidine gluconate?
All right, so the use of chlorhexidine is one of those more controversial things. I haven't seen any negative on it, and it's somewhat equivocal. People talk about it. It definitely kills bugs. There's a group out there that believes it inhibits this group of enzymes called MMPs that potentially causes long-term bond failure. I added it to my protocol of adding 30 seconds after etching, but in reality, it probably actually does nothing. So if you want to add one thing, I realize there's a lot of young dentists out there. Add the glutaraldehyde. Add the glutaraldehyde.
Okay, I'm gonna just go over. I'm just gonna run over 4 or 5 other issues. Curing lights. There's some people that think the number one variable to failing composites is they were undercured because the curing light wasn't strong enough. It doesn't work anymore. It's broken. What's your thoughts on curing lights?
Well, not the biggest expert there, but I would agree that is a problem. And I got to tell you, when I'm teaching courses, I'll tell you what I see a lot of dentists do is they're not even paying attention to where they're putting the light. To tell you the truth, and from lights, if you double the distance of a light from where you're curing, it's 1/4 the power. So if you just move the light away a little bit, you lose an amazing amount of power. So I'm wondering, and in fact I'm sure that a lot of the loss of energy is just poor placement of light. And then you add on top of that the poor quality of light. Yes, I would agree that is a big issue. I would agree that that's a big issue.
And there are also some people talk about pulse curing. Some people don't know what pulse curing is. What are your rant about pulse curing?
Well, okay, where the theories are today on that, and if anybody wants to read, Fred Rugenberg is the expert in that, is that pulse curing doesn't seem to matter where you're going, where the light stays on and sort of ramps up. There is a little bit of credible research that if you turn the light on, and then turn it off, that the stresses will relax. So if you want to do that, that's kind of what I would do. I would cure it for a few seconds and just turn the light away for a few seconds if you want to take advantage of that. So I wouldn't essentially nuke it for the whole time, because you can create some stresses that might create a little bit of a problem. So I don't worry about a light that has all those abilities. I'll just kind of tack cure for a few seconds, turn the light off or turn it away for 3 seconds, and then do my final cure, so I don't have to pay for a super expensive light with a lot of bells and whistles.
What did you say his name was? Fred what?
Fred Rugenberg. Rugenberg.
How do you spell that?
Rugggenberg.
Is he German or German?
Um,
Another
I
another
think,
another thing. You know, we're talking about the market, 150,000 general dentists. A lot of people, they just don't. I mean, if you were born and raised 30 years ago, like I was, where you put a small increment cure, a small increment cure, a small increment cure, they just don't buy into bulk fill.
yeah.
But do you? I mean, what would you say to some old guy who did for 2 decades increments and cures, who's now supposed to fill up the bottom half with one increment cure, and then the second half, two 4 millimeter increments? What do you say to that guy about bulk fill?
Okay, well, I guess I'm not to use a bulk fill. Maybe clarify a little more for me. I'm not sure
Yeah,
what
I
you're
mean,
asking.
they still think they still think doing increments and curing in increments is just a Mercedes Benz, and a bulk fill might be like a Chevy. Do you think it's a higher quality to do increments and cure as opposed to a bulk fill?
Well, I mean, certainly you're going to get a higher quality aesthetic result because you can then control how it looks in the 3 dimensions of color. But I don't think that you're going to get actually a better functional or long-term result. I don't think there's any science that shows that. And the reality is the young dentist is not going to be able to put an hour, 2 or 3 hours into get that beautiful result that you show in magazines. And they're going to have to get a good, decent, long-term functional result. Yeah, you can't do it in 1 increment, but you could do it in 3.
And I know you have no way of answering this question, but what percent of those magazine articles do you think are photoshopped?
Well, I wish it wasn't true, but I would say well over half.
Oh yeah, when you're on
Well,
my side of the equation, I have own a media company. Oh, trust me, we all the editors all know each other. I'd say it's like 80% come in.
yeah.
But anyway,
I,
an,
you
an,
pulled the number out of the air. I was going to say 80 to 90, but I was being kind and well over half.
so some people when they look at their final restoration of bite wing, they just think it looks better if they put flow on the floor, especially in the boxes. What do you think of someone who puts flow on the floor just for that radiopacity seal? A really radiopaque flowable for kind of radiographic aesthetics.
Well, I actually, from a functional and seal point of view, I actually kind of like that. So I use a functionally flowable. I'll put a little thin liner down, but I don't cure that. I know people actually cure it. And then I'll put my first layer on top of that, and that's pushing it into any little microscopic areas that the viscous material won't go into them. So I actually think that's a good technique. And then
what flow do you use?
I actually had Bisco make me a special material that I used for a long-term mock-up called Reveal. But any functional flowable, 3M makes one, Filtech Supreme Ultra flowable. Almost everybody makes one now. Voico makes one. Shofu makes one called Beautiful. Just a functional flowable that has some radiopacity.
Everybody claims that the trend is going towards minimally invasive dentistry. I mean, you see it with surgeries all the time. You see patients come in and old grandpa will pull up his shirt and show you where, they removed his gallbladder and he's just got two or three little dots.
Yeah.
Whereas 30 years ago, it was a Frankenstein flap with staples in it. Are you really a minimally invasive dentistry if you switch from direct MODs to indirect CAD/CAM milled restorations? I mean, what is more minimally invasive, a direct MOD or a CAD/CAM chairside milling machine?
Well, I think they both could be minimally invasive, right? They theoretically both could be minimally invasive. To me, I think there's nothing more minimally invasive than a well-done direct restoration. Because, it's interesting, Howard, you've been at this a long time, just like me. I think people kind of misunderstand the benefit of a minimalistic direct restoration. They cut all of these, perfect preps when, we want to cut. There's some guidelines to preparations that we need to cut, young dentists out there. We need to have clean margins and not unsupported enamel, but you don't need to cut like a GV black prep for a composite, because composite doesn't have to have smooth on internal finish lines. We want to save tooth structure. That's the concept of minimalistic dentistry or minimalistic anything, to save healthy tooth structure. So we don't have to cut all that away. We just need a clean finish line. So it saves time to do a minimalistic direct restoration. For an indirect, you do have to cut all that stuff away and smooth walls and do all that internal. So I actually think direct is more minimalistic.
If it was your daughter, your wife, your mom, your sister, and she wanted a smile makeover on her upper incisors, or a smile makeover, canine to canine, upper 6, 8, 10, would you do direct composite veneers, or would you prep them and do indirect veneers?
Well, I've gotten to be. I'm also a master ceramist. So if it's kind of one or two teeth, like a class 4 or something like that, and I get a finish line, I would do direct. Okay, but if it's multiple teeth, it's faster for me, honestly, because I can do porcelain and I'm really good at it. I'm gonna do feldspathic veneers, and I can do it with. Theoretically, I could do it with no prep, but usually I'm going to do a micro prep, and it would be the same for me whether I did composite, the same amount of tooth structure for me, for a veneer really, as it would be for composite or porcelain, for me personally.
By the way, you just mentioned GV Black, and Chicago now has a monument to him. Have you seen that?
I have not.
Next time you go to Chicago, to the Chicago Midwinter meeting, you got to take an Uber to the GV Black Monument and take a selfie. I think it's just cooler than cooler. I want to ask you another question. You're a master ceramist. You're probably the most highly qualified aesthetic dentist ceramist I've ever had on the show. I was so excited that you decided to come on. But they coming out of school, they're $250,000 in student loans, and they think in order to be a high-tech dentist, they need to spend $150 in a CAD/CAM machine. Do you think to be a high-tech, cosmetic, exquisite dentist, you need to invest in a $150,000 chairside milling machine or not?
No, they don't. Okay, they absolutely don't. At a point, chairside CAD/CAM. It's very good today. There's no doubt about it. Okay, and that needs to be a business marketing decision. You're a business guy. We have to be business people too. If the business decision, if it can pay for itself by increased patient flow. And increased turnaround, they can generate dollars and pay for itself, then it makes sense. But that doesn't make them a better dentist. It doesn't make them a better cosmetic dentist. I read a great book of a guy that was an economist, A Theory and Practice of Economic Wealth or something like this. And the guy talked about technology. He said you should pay for technology if it increases your business, the cost of technology, and you can pay for it in 1 year. So if that machine cost $150 as an example, you should generate a minimum of $150,000 new business in 1 year. So if in the dentist assessment they will get $150,000 of new business, it's worth it, according to this guy. Oh, The Theory and Practice of Economic Alchemy was the name of the book. Paul Zane Pilzer. And
theory and practice
of economic alchemy.
Of economic
alchemy. Paul Zane Pilzer.
Alchemy, almost done. Paul Zane Pilzer.
Pilzer. Pilzer. Paul Zane Pilzer.
Pilzer.
Yeah, and they should have a scanner to upload to the lab. They should have something like a Trios or Trios.
I want to stop you right there. Back to CAD/CAM. What percent of the numbers I hear that are most real is that 12% of dentists have CAD/CAM, and to me that's a red flag because practice management software come out, and that's in over 80% of practices. Digital X-rays came out, that's in over 80% of practices. But when you say, do I need a laser? It's like, man, lasers didn't even penetrate. It's the same as CAD/CAM. It's about 12% of the dental office bought a CAD/CAM or laser. If it was a must-have technology and all your colleagues have 8 to 12 years of college and got A's in calculus, physics, and geometry, to me, what percent of the market has to buy it to where it's a must-have technology? I think when only 12% buy a CAD/CAM or a laser, that doesn't mean it's a must-have if 88% of the dentists don't have to do it. Whereas if 80% have digital X-rays and practice management computers, then it's a must-have. Do you agree with that type of theory?
Well, yeah, that's kind of what I was saying. It really isn't a must-have, okay? And if they want to enter the digital world, then they probably should have a scanner only. And the scanners are getting pretty good.
Okay, now I want to stop you at a scanner too, because here's my thought. So I'm old school. I got out in '87. I've been using 3M's Empergum back when it used to be owned in Germany by SB, and then Minneapolis St. Paul bought the SB, so now it's 3M Empergum. So it cost me about $14 an impression in a triple tray. We're talking to dental kindergarten and dental school, single unit crown. I take a $14 Empergum, send it to my lab, and they make a zirconium crown. But 3M wants me to buy a $14,000 true definition scanner and trade in my $14 Empergum. So talk to me. And then it's not just the $14,000 oral scanner. I have a yearly maintenance fee for that. Right. What is that? $200 a month? What's 200 times 12? $2,400 a year? I don't even buy $2,400 a year of Empergum. So talk me off the cliff. Talk me down from the balcony. Why should I switch from a $14 Empergum to a $14,000 oral scanner with a $200 a month, $2,400 a year licensing agreement?
Well, where I was going to go in the next area, where I was going to go was instead of you having a milling machine and you having to be a lab and doing all those kind of things, the next thing that we're on the cusp of, and where we should have been with this, in my opinion, and I coined the term digital dental team, and I wrote a couple of articles about it, digital dental team.
When are you going to write one for Dental Town magazine?
Yeah, I'd be happy to write one for you. Because
and you know what I would kill for you. I swear to God, I'd fly all the way down to Alabama and buy you a beer if you did it. These millennials love the online CE. We put up 401 online CE courses. They're just an hour long. They've been viewed over 500,000 times. They just love it, man. You would give so much credibility to our online CE if you'd graciously give us an online CE course.
Yeah, I'm kind of at that point now where I'm tired of writing for scientific magazines because only scientists read it. I want people to read it and do it, and see it and do it kind of thing. Yeah, so let's definitely talk. I'll interface with Ryan on that. But the digital dental team concept is, here's what I believe. The reason why CAD/CAM hasn't penetrated chairside to the big numbers that they would hope is dentists find out they're having to be dental technicians way more than they want to be. You know this. All right, and it's just spending too much time not being dentists. And the concept that I have, and we're on the cusp of this, where dentists just basically scans in their mouth, and the speed with which, and I'm actually working with the ability to turn zirconia around, and we can turn some of these things around in 2 or 3 hours. So imagine this: you prep a couple of onlays, you upload it to a lab close by from your Trios or another type of scanner, and within 2 or 3 hours, they deliver those restorations to you. So you now have the ability to do same-day dentistry. But you don't have to play technician. You don't have to adjust contacts. You don't have to stain and glaze. You don't have to sit there and design. This is where we should be, Howard. This is, and we are right there. We are just right there.
I agree. When you go to all the seminars, they sit there and tell you that all these chairside things are done an hour. A patient comes in with broken teeth, you numb, you prep, you scan, you mill, they're out in an hour. Then you go in the field, and it's 2 to 3 hours. And then people are calling up saying, people are calling up with an emergency saying, I broke my tooth, can I come in now? No, I'm sorry, that chair's tied up for 3 hours because the dentist just demoted himself to a lab tech, and he takes him 3 hours to get this done. I want to add just some more, this Dentistry Uncensored, I just like to randomly fly through what they're all asking on the message boards. A lot of people don't, it seems like most of the people that lecture are from Beverly Hills or Key Biscayne or Manhattan, but all the dentists taking the courses are from Parsons, Kansas, and Roanoke, Oklahoma, and they're treating middle class and poor, and grandma's got this big 6-unit bridge and a big old chunk of porcelain broke off, and she ain't got the money for a new 6-unit bridge. Can you successfully really repair that broken porcelain on a crown with a chairside composite?
Okay.
And they just moved their headquarters from Tokyo to Switzerland. Do you think that was about their tax rate, or their tax rate?
Or maybe the tax rate.
I want to another thing you talked about. Our both of us admire Ray Bertolotti. He was with Danville Engineering out there in where is that in San Fran? It was in Silicon Valley somewhere. It was in Danville, California. Yeah,
Dan.
and but anyway, he was also famous for selling a sandblaster. Some old school guys always want to sandblast out their zirconium crown before they cement it. Some of them want to sandblast, like you're talking about porcelain repair. They'd want to take that Danville microetcher with aluminum
Right.
oxide and sandblast that. Some say it increases bond strength. Others say it doesn't. What's your thought about the Danville microetcher?
The absolute science is if you're going to adhesively bond zirconia, you have to sandblast it. Now, here's the thing. The original zirconia, tetragonal, the old stuff that we had that was opaque, that we all knew from before, like the original lava, it does not weaken. The new cubic zirconia, it weakens about 50%, but it's not a problem if you bond. So dentists, this is really so important. I've done some research on this. It's coming out. If you're going to conventionally cement zirconia, the new zirconia, the cubic, don't sandblast it. If you're going to use like glass ionomer, don't sandblast it, use glass beads. If you're going to resin cement it and you want to bond it, you do want to sandblast it with 2 bars of pressure, that's 30 psi. So you sandblast it, aluminous oxide, 2 bars of pressure, that will weaken it, but the weakening is not a problem because the resin cement will compensate for that. So 2 simple answers. Conventional cements like glass ionomer, glass beads to clean the inside, resin cement, aluminous oxide to increase the bond strength. So the answer, Howard, is the absolute science shows it does increase the bond strength.
Now with the internet, when we were little, we talked to dentists in the same city and county. Now on Facebook and Dental Town, you're talking to dentists from every corner of the earth. Why do you think places like Australia and New Zealand use so much more glass ionomer than America? I mean, it doesn't seem like they could both be right. It seems like in America, there's almost little use of glass ionomer. Then you go to Australia and New Zealand, and so many of them just love the stuff and use it every day. Why the disparity? Why the difference?
Well, simple answer was the sandwich technique was developed there. A lot of the science was done there. And for the sandwich technique, which the sandwich technique by definition was underneath composites, that you put a layer of glass ionomer and then put composite on top, and that seems to work. And they haven't had a real big problem with it. Different techniques developed here that also work if done correctly. So that basically shows you that there are more than one technique that works. So that's working in Australia, and until they see in New Zealand, until they see a wholesale failure rate, it kind of shows you that basically it comes down to good seal, right? Good seal, some of the things that we know that are absolute, and a good peripheral seal that several things could work.
So are you talking about Graham Milicic out in New Zealand? Do you kind of credit him with that technique?
Yeah, he's one of the guys that was a major contributor, yeah.
Yeah.
His name comes to about.
Yeah, couple more questions.
Yeah.
Back to burrs. When you go into, the people that are promoting independent private dentistry are actually the ones killing it because they're saying you need to upgrade your $20,000 pano to a $100,000 CBC. You need a $145,000 CAD cam. You need a $135,000 NAP laser. You need to buy all this stuff. Well, when you buy out, that's what happened to healthcare. As the physicians started buying all these MRIs and ultrasounds, the solo practitioner need to be in a group practice. So group practice is growing fast, and in a group practice, what kills the dental assistants and almost drives them to drinking is that if you're working with 3 dentists, they all need 15 different burrs to do a damn filling or a single unit crown. And then when they go to the dentist and ask them, can we just agree on 5 burrs for a filling and 5 burrs for a crown, they look at her like she's a demon from The Exorcist. Like,
Yeah.
how do you get a group practice to agree on a burr cup, and how many burrs do you need to do a crown prep, and what number of burrs would you say you're now officially neurotic and need psychiatric help?
Great story. Just to add to the funniness of that, when I did private practice before I did academics, and most people do that reverse. They start academics and private practice. And I remember watching the guy do a class 2 amalgam, and he used 17 burrs.
Yeah, I know.
Literally, that was 17 burrs. But well, the only thing I could possibly say about that is when I designed my burr blocks, I try and keep it same thing, 5 or 6 burrs, and then I would design a burr block, and you got to have those discussions, obviously, where you have Dr. Smith's or Dr. Jones' burr block, and then I would have the standardized burrs, and then I would have like 3 or 4 extra slots that are just open. And then when the doctor so-and-so practices, you just grab those 3 or 4 for that person. But yeah, you have to have some standardization. And I always try and tell people, as you get older, you get wiser. You try and do one burr as much as you can. And because all of this stuff adds time. Yeah, we want to be as best as we can. We also got to pay the rent too. And you have to learn to do those things. You just have to. I'm private practice fee-based, but still there's just a limit of what you can charge, and there's time involved.
There's another thing that confuses the kids to where, every once in a while they'll read an article that a 57 burr might be is much more atraumatic than, say, a 557 with crosscuts. And some people are saying that when you use some of these aggressive burrs, you're microfracturing and shattering the enamel and all that stuff. Do you think some burrs are too aggressive? Some people say I will only cut with a diamond. I mean, what are your thoughts on microfrackage from burr selection?
Well, the research actually shows that that's true. So how I handle that, I use the most aggressive burr to do the gross reduction, and then I use a fine diamond to finish for just the last 0.2 of a millimeter, and that I believe that solves the problem. So that I get the best of both worlds. That's how I handle it.
And then the next question is a 2-part question. You talked about your burr block, but what about your polishing? And obviously everybody polishes anterior composites on incisors far more than on a posterior molar. But what is your polishing kit for an anterior composite?
I like Ron Goldstein's burrs, that he developed, his ET burrs, ET carbides, and then I use the fine and the super fine little rubber points from Brasseler. That I guess I'll give Ron Goldstein credit for him developing those. I like the enamelized from Buddy Mopper's company. His name escapes me, his company right off the top of my head. And I got to tell you a little trick.
Cosmetic. In Chicago.
Yeah, and I'll tell you a little, everybody, you need to try this. So this is the coolest little trick I learned from a dental technician. And he was a denture technician. And I think 2 companies sell it. I'll give you the name of 2 companies in a second. So I was watching this guy polish denture teeth. And composite denture teeth. And I thought, hey, this would be really good. Never composite denture teeth. This would be really good anterior composites. And it's called Leather Buff. Leather Buff. You can get it from Brasseler or Comet. And it's a small laboratory product, but it works up to first bicuspid. You can get it in the mouth up to first bicuspid. It goes only in a straight nose comb, and it's a little small thing that looks like a chamois. And it's the best thing, little pieces of chamois, leather basically, and it's the last thing I do to put a high shine on composites. And you do everything that you're used to doing, and it's the last little final polish, and it brings up just an amazing finish on composites, or bisacral, or any form of acrylic, called Leather Buff from Brasseler or Comet.
And what's funny is when you say Brasseler or Comet, originally when Peter Brasseler started Brasseler burrs in Savannah, Georgia, he was just reselling burrs from the German company Comet. And then Peter Brasseler passed away, and then over the years, Brasseler started making their own burrs. So now you can actually buy Brasseler and Comet burrs in the United States, but originally they were just the distributor for Comet. And Buddy Mopper, that is so amazing. He's an established, well-respected cosmetic dentist in Chicago with the company Cosmodent, but he started out as a pediatric dentist.
Oh, I didn't know that.
Yeah, he's a pediatric dentist, which leads me to I hope I'm not stealing too much of your time. I can't believe you gave
No,
me an
I'm
hour of your
okay.
time. But
No, I'm okay.
here's another very stressful thing for young dentists when they love literature. Again, you look at 100 million insurance claims filed for all claims, and it just says it looks like a heart note with like four pulses. You know, tooth number 3, tooth number 14, tooth number 19, tooth number 31. I mean, 80% of the dentistry billed out is on four flipping teeth. It's these first year
Yeah.
molars. So now you're a dentist, and it's your own daughter being born, and her 6 year molars just erupted, and this is your baby, and that's the tooth most likely to be extracted someday. And they look at this sealant research, and so much of the sealant research says that you're acid-essing pits and fissures filled with crap, and you're putting this plastic layer up. They chew off. So much of the research says that in 1 year 40% have all failed, and that in 2 years 80-90% are filled. Do you believe that? And then there's the other side where they say, well, maybe I should get a coarse diamond and take out the preps and fissures, kind of like a minimally invasive old GV Black, and blow out those. But talk sealants, because you're a master in adhesion.
Right.
Do sealants even work? And if it was your own daughter or granddaughter, what would you put on her four newly erupted 6 year molars?
Well, not being an expert on sealants, but being an expert on adhesion, here's what I would do, and I don't see him at that age. But the clear answer to that question, understanding adhesion, I would at least sandblast the surface of the tooth, okay, to make sure I got the biofilm off, like you said, the crud, and then I would do an adhesive procedure, and with my loops, I would make sure that there was no caries. The obvious caries. And it's also clear from the research that if you seal caries in there, it'll at least arrest. If there's microscopic caries, it will stop if it's sealed. If you take its food supply away. So I wouldn't have a problem. If it was my kid, I would seal it, but the key is it has to be sealed. And it has to be clean.
So would you use the Danville microetcher?
Yes, I would use the Danville microetcher.
That's what I use.
I have several.
Yeah,
that's what I would do. I can't practice with that. And let me just tell one thing about a laser. I wouldn't buy a bunch of big lasers. I would just buy a small diode laser. It is a must-have for me. You mentioned lasers. I do so much tissue recontouring with a diode laser.
Which diode laser do you use? AMD?
Well, I use the one from Ivoclar, but I heard they stopped selling it recently.
Really? Huh.
Yeah, the Navigator.
I used one from AMD, which stands for Alan Miller Designs. He was started out in Indiana. Now I think he's in LA. But
for the young dentists out there, you do not need one of these big Nd:YAG or Erbium mags or anything like that. But a diode laser just for soft tissue, a little bit of minor crown lengthening, tissue leveling, it's phenomenal. I use it every day.
So we went over the hour. Can I ask a couple overtime questions?
Sure.
It seems like to me, dentistry in many respects is going backwards. When I got out of school, the go-to restoration was amalgam, and it lasted 30 years because it's so antibacterial. Half the amalgam's mercury. You'll never find that in a multivitamin. The other half is tin, silver, zinc, copper, tin, the hygienist, stannous fluoride, very antibacterial. Silver, look at the pediatric dentist using silver diamine fluoride. Every ingredient in amalgam is toxic, and bugs don't like to grow under it. Now we've replaced that for this aesthetic health compromise with this inert plastic composite, and a lot of good research that I see says that posterior amalgams last twice as long as composites. So now the trend in composites is, well, maybe we can kind of make them bioactive or antibacterial, and you see these composites that are now claiming almost like we're going from inert to active properties and ingredients. Do any of those excite you? Do you like any of those? Do you believe in any of those products today?
Okay, the bioactive composites, so far what I've seen, nothing appears to be bioactive like they would like them to have, right? What we would love to see were just some rapid growth of secondary dentin. Do we see some activity? Yes. But the biggest problem with them is that they look like crap. I mean, they're not aesthetic. We need something aesthetic. So there's some good materials on the market. Calcium silicates. Like I would just go to something like TheraCal. Put down you've got deep caries, or you want to do a indirect pulp cap, TheraCal LC or TheraCal Dual Cures, and then just put your from Bisco. Phenomenal material. They've got some good research on the material. And there's a couple of knockoff products that just don't come to mind right now. That'll give you your little bioactivity, form secondary dent, and then do your composite on top. Simple.
That's what I would do. That Bisco, we had the founder on, Byung Sa. That is just, what an amazing mind Byung Sa is. Founder of Bisco, just an amazing guy. You're talking about bioactive as opposed to growing secondary dentin, but do you think someday the active ingredient will be antibacterial? You know, something to kill Streptococcus mutans when it comes to want to live underneath it?
Yeah, I mean that's going to be the goal, to have something that prevent or at least neutralize the effect of bacteria. Absolutely, yes, that's the goal. Whether they get there or not, we'll see.
Okay, last and final question. When I ask any dentist, I don't care if they're 55 years old like me. I mean, I don't know how many fillings I've done from 1987 to 2017, 30 years. But, you know, when you ask them, what's the worst part of an MOD Composites? It's the gosh darn contacts. I mean, and whenever you get done with the amalgam, you get and Jan hands you that piece of floss, you're just like, oh, please. You know, what advice would you give on making interproximal contacts?
I couldn't agree more. I couldn't agree more. I mean, you got to wedge them, and you buy one of those special systems like the Trios ring system from or the V3 ring system to wedge them. And you know what? The reality is, if you just get large interproximal spaces, you maybe want to consider indirect. And, you know, the technique where you build up the interproximal first, that I don't know who came up with the technique, that's a good idea. You know, where you build that interproximal wall first and cure it. That seems to help develop a contact. You know what I'm talking about, right? So that seems to help. I mean, that's not my main area of expertise. Mine's more indirect. I mean, I'll do them if I have to, but if it's just large, I'll just do indirect. So.
And my last question. Are you a big believer in caries indicator, like Seek from Ultradent or whatever? Do you think routinely, again, first 5 years out of school or at any age, caries indicator, yay or nay?
Yeah, here's how I think about it. I'll generally put it on just once when I'm getting close to done, because I know there's a lot of there's false positives and false negatives, just to see if I may be missing something near the margin, because I obviously don't want to have caries at my margin. And knowing that the research that if you left a little bit of caries inside your prep, as long as it's sealed, it's not a problem. I just want to make sure I'm not missing something in a margin in a box form. So that's my thought process. So I'll just do it once. And I won't keep doing it, and keep doing it.
Well, man, in a world of dental fish, you are a blue whale. I've been a fan of yours for decades. Just thank you so much for all that you've done for dentistry. Thank you so much for coming on the show. It would just be the hugest honor if you would do an online CE course for us, because these kids, they'll download it on. We have 250,000 dentists from all 220 countries on Dentaltown, and 60,000 of them have downloaded the app. And what they do is they take that online CE, they sit at their house with Apple TV, they throw it up on their big screen. I assume they're drinking beer while they're watching it, and it's just they just love that stuff. So if you ever want to write an article, build us an online CE course. Ed, thank you so much for all that you've done for dentistry, Dentaltown, and for coming on and talking today on Dentistry Uncensored.
Great, thank you, and have Ryan follow up with me on that, okay?
Okay, buddy, have a rockin' hot weekend.
All right, thank you. Take care.